Hello and welcome to Beyond the Trip, a psychedelic therapy podcast with me, Dr. Esme Dark. During this podcast, I'll be bringing you conversations with thought leaders and other inspiring humans, exploring a wide variety of themes relating to the use of psychedelic-assisted psychotherapy in the healing of human distress. Whether you're an aspiring therapist, already a therapist, or just simply interested in the emerging field of psychedelic therapy, then this podcast is for you. Join me for a journey into the psychedelic world. Before we get started, I want to take a moment to acknowledge the traditional custodians of the unceded land on which this podcast is recorded, the Wadawurrung people. I pay my respects to elders past, present and emerging, and I extend that respect to any Aboriginal or Torres Strait Islander peoples listening today.
Hi, everybody, and welcome to this episode of Beyond the Trip podcast, which is one of the episodes in our series looking at psychedelic-assisted psychotherapy in end-of-life and palliative care. We'll also be exploring grief in another episode. And in this episode, we talk to one of the real pioneers in this space in Australia, Dr. Margaret Ross. Dr. Marg Ross is a clinical psychologist, and she was the chief principal investigator for Australia's first psychedelic-assisted therapy trial. Her team investigated the use of psilocybin for end-of-life distress. She has trained therapists and medical professionals, both nationally and internationally, in psilocybin-assisted therapy for end-of-life care and the psychosocial aspects of palliative care. Her work is particularly informed by an interest in cultural rituals and altered states of consciousness at end of life. She's had the privilege of receiving instruction from various Indigenous medicine practitioners, deepening her interest in the traditional healing practices and the intersection that this has with contemporary medical practices at the end of life. Now, this episode was recorded actually a little while ago now, maybe just less than 12 months ago, and I've been waiting to release it with the other episodes during this kind of mini season, I guess, of episodes exploring psychedelic-assisted therapy in the end of life and all that goes with that. So this is a two-parter because in this first episode, Marg was not able to discuss yet the findings of her research. It wasn't published. And so I actually have invited her back much more recently to come and talk about the results. So in this episode, we're going to be talking about the setup of her trial and what it was like to set up the first psychedelic research trial in Australia, her research in palliative care and her work in that space, how psychedelics are much more about transformation, not symptom reduction. It leans into the personal, and I, for the very first time, talk a little bit about my own near-death experience and that impact that has had on my career, my life, and who I am. And Marg really flips the interviewing onto me for that part, which was really quite vulnerable for me. And so there was, if I'm honest, a little part of me that was nervous to put this out. So I hope you enjoy it. She shares about her experiences in this with her own illness as well, and how this has shaped her work. We talk about therapist burnout and sustainable models of working and cultural perspectives on death and dying. There's many other things. This was a great conversation and we went for quite a bit longer than we thought. And so I'm really delighted to be bringing you this part one of the conversation with Dr. Marg Ross. Good morning, Marg. Thank you so much for coming to Beyond the Trip podcast and taking some time out of your Monday morning, which is a public holiday today, to be here with me. I feel really honored that you've chosen to spend some time with me today. I feel really excited.
Oh my God,
about
not
this.
at all. Thank you for having me. This is important talking.
Yeah, absolutely. And I've been, you and I have kind of come across each other in our fields of work and have both been working in the space. You, way before me, were involved, and then I kind of met you through work a few times, and so it feels really lovely to have you here.
Yeah,
because
you were someone who I'd heard about a lot. You know, you were actually one of the people who got the very first psychedelic research trial in Australia off the ground, right?
Yes.
Yeah.
Yes, which
So
was an extraordinary journey. It doesn't feel like I've been in that long, I guess. That's the other interesting part about it. I don't feel like I've been here in the arena all that long. But getting it off the ground was a very interesting experience. We'd had, a decade of various research groups trying to get psychedelic research back in the Australian research arena, and it just was rejected again and again and again. I think it was just a good time. I think the cultural uptake of the idea of psychedelics was very much in the public psyche. I think, Michael Pollan had just released his book that same year that I had submitted my protocol. I think that was released in the May. I submitted in September. I think it was doing all the podcasts and everyone was talking about their ayahuasca experiences that helped things. But more than that, the science just spoke louder than anything that I could write. That was a massive surprise. We were not expecting it. And we were in no way prepared for what happened next. But it was the beginning. Yeah.
Yeah. And do you want to share, just for listeners who maybe are not from here, like what you actually were doing? Because you were working with psychedelic-assisted psychotherapy with end-of-life care, right? And maybe it would be helpful for people just to understand the protocol that you took people through and what you were actually doing before we get into the rest of today.
Sure. So prior to kind of launching this, I had worked in palliative medicine and psycho-oncology, but more at the kind of the severe end of cancers, and then also end of life just in general, not just cancers. So things like, end-stage cardiac failure, end-stage lung diseases, motor neuron disease, etc. And I'd been working in there a decade, and the problem that we saw and we would frequently come up against is if people weren't responding to our traditional treatments that we could offer them, which was medication or talking therapy, creative therapies, they just remain terrified, and their families, like, it was really awful to watch this. They would withdraw. They wouldn't, they wouldn't really respond to their usual pain meds. Like they had an augmented experience of pain. They couldn't sleep. So I was looking for emerging therapies that we could potentially offer to our patients, and nothing really was new. We did have palliative sedation, which is a really, really blunt and very, it's a last resort kind of thing where you have to kind of knock someone out for a few hours so that they can just get some respite from their suffering. So I was looking at this. They had, there were 2 trials that came out of the US in 2016, actually an earlier one in 2011, a pilot study from Charlie Grob. This was their reemergence after, the big decades-long hiatus of psychedelic research. So, that really inspired me. The work of Roland Griffiths and Stephen Ross, who had done work in cancer, and they were able to really quite rapidly bring down anxiety, and that was sustained over a period of about 6 months follow-up with some psilocybin-assisted therapy. And I went, okay, I think, this would be great. Where are they doing this? And no one was doing it. So we wanted to do that. So we did, and we were kind of looking, we kind of had to start really with our own protocol. We were looking a little bit at what they had done in the US, which was extremely conservative, I have to say, to the point where it would have actually eliminated a lot of people who would have otherwise been able to safely take it. So some of our work actually was refining that protocol and changing it a little bit so it was a bit more inclusive for people who were taking particular chemotherapies, for example, that would have usually been excluded, but they could safely take it. Pretty happy to say that, from a safety point of view, we had no serious adverse events. People who were very sick, even with end-stage cardiac failure, tolerated it beautifully. So we were very, very lucky, actually. But the thing that was, I think, more unique, I guess, about our study is that the entire team was staffed by clinicians. who were
Yeah.
working in the field of palliative medicine. So we knew where the risks were that we may need to mitigate. And we were doing, weekly, bi-weekly meetings just to see how people were going. So we had eyes on them like you wouldn't believe. So yeah, lots of safety in there, but actually it turned out that people tolerated psilocybin really well, even at quite advanced stages.
That's great. And you were working in a dyad, right, with your therapy partner, Justin Dwyer, is that right? Yeah.
Yes. Yeah.
And did you take how many sessions of therapy did people have in the protocol? Like, and how many doses did people have? Did that depend, or was it all the same?
Look, largely it was 3 prep sessions. The way that we had to do it, and shout out to my diet partner, JD, who we've gone through so much. And you would understand that.
I do. Yeah, I understand that. And maybe we can talk about that in a minute.
Look, it was profound learning. So we had a protocol that was slightly different. And the reason being was more because we had very tight timelines. By which I mean, like our patients, a number of them were still on palliative chemotherapies, which meant that they were, 2 weeks chemo on, 1 week off, or 1 week on, 1 week off, or the 1-8-15, kind of dose protocols, which meant we had 1 week where they were not fatigued, where they were not really sick, and they were doing okay. So we literally had to do boot camp. So we would see them Monday, Tuesday, Wednesday, consecutive days for preparation, dose them on the Thursday, and integration on Friday. And that was because we had to just, that was the time that we could do it. We had to work around their treatment protocols. That was just not an option. And that in that way, we stumbled across some interesting findings, which was that they had quite a degree of momentum therapeutically. And so instead of, seeing them a week later or 2 weeks later and spending 20 minutes of the session getting back to where you were the previous day, they were right there the next day. And we just went deeper and we went deeper. And so it was like boot camp. And the way that they treated it was that they really tried to protect that time, and we encouraged them to really protect that time so that they could really optimize the experience, with more reflective kind of, preparation, journaling, reflecting, spending time in nature, doing the things that were more meaningful to them, so that they could really get as deep as they wanted to go. So that's how our protocol was, perhaps a little bit different, but it was it had a lot of advantages, I have to say.
I'm just thinking about that from a therapeutic perspective. Sometimes you get to something really deep in a therapy session, either a prep or an integration, but and then the person goes away and things come up, and they kind of, maybe their protectors, in my IFS language, come up, and the defenses, and then you kind of have to kind of start again almost in the next session. But then if you're working with people in that kind of intensive way, I can imagine that could be really, really helpful for getting really, really deep with people, which is amazing.
For the right person, absolutely. I think it's not for everyone.
None of this works.
Protectors.
Exactly. Absolutely, they're super important.
So that was, I think, that's and they got a very good sense of us, and we got a very good sense of them. In such a short time as well, and how they were going to make use of us in the dose session, in terms of casting us in roles, which was very interesting. So that's how I think our protocol developed, and was perhaps a little different to the usual, TRD or anxiety ones, which are a bit more spaced out, which certainly has more advantages.
It's just a different client group in a way as well. I guess it depends, but yeah. And it's interesting that that's quite interesting to me that even people with end stage heart disease and heart failure were able to tolerate the psilocybin, because so often those people with heart problems can be excluded in general from a lot of research, can't they? So that's a really important finding, actually.
And we certainly had the elevations in blood pressure and heart rate. They were transient. None of them went beyond about 5 minutes. So all expected. non-clinical, didn't need any attention from the study doctor. It was just more monitoring, and then they kind of, in the waves that psychedelics can come, they sort of crest and then fell, and it was fine.
Yeah.
So
And so you finished that study now, right? So where are things at the moment, and what are you able? I know you can't go into lots of detail. I'd love to do that, but
close. I know.
Yeah, soon you have to come back on, Marg, when you're allowed to do that.
Oh, I'm so sorry. I know, it's like fine. Win. Look, I never say we're very happy with our results. But I can say that, from a safety point of view, very well tolerated. In such a medically unwell cohort, which is, wonderful. There are things that we need to be mindful of. It's not to say that it's still across the board safe. There are certainly people that we wouldn't give it to. But I think much more tolerable than people first thought, particularly in things like cardiac failure. Yeah. So
can you, I have who would you not give it to, from a therapeutic perspective, or do you mean from a health perspective, or both?
I kind of both. I mean, it's a tricky one, isn't it? I think, God, there's so much I could say about that. From a medical perspective, obviously, if people are very, very unwell, and if they've got things like, obviously, type 1 diabetes, we know that as an exclusion, because you can't tell if they're having, a hypo event. But also things like, if they're very, very unwell and they've had delirium, which is a big thing in palliative care, particularly towards the end. So things like that. If people have got some acute issues going on, if they're in urinary retention, things like that, we can't, and we wouldn't proceed. There's certain things that you look for in cancers. I won't get into it as a whole.
That's fine.
It just means that they can move from stable into unstable territory quite quickly. So you would have to exclude on that basis. But if they're pretty stable and their treatments have been optimized and the medical clearance is the thing that you're looking for, then you can proceed.
And there's a whole therapeutic piece here too. And people ask me this question a lot, who is it not for? And in terms of, I'm not a medical person, so from a therapy perspective, and I have so many different answers to that question, it depends, right?
And I think that's the thing. It's well, what do you say? I've got,
I'll go in a minute. You go first. You or I can go.
There's the whole. We know there's the usual exclusions. If you've had a psychosis, if you've a manic episode, first degree relative, we know all that. I know that there's some movement toward things like bipolar 2 that they're looking at, which I think is very useful. But it's I find it difficult to answer that one, because I don't think this is such let me just gather my words a bit. It's an existential experience, and we're kind of looking at it diagnostically to say, well, no, if you've got that diagnosis, you can't. And I think it's so much more about where that person is at, what they're prepared to do, what they're looking for, how active they're going to be in this process versus, so there's so many things. And it's not about, oh, well, this person would fulfill criteria, therefore it doesn't necessarily mean that they're going to know what to do with this, or, some people can discard the transcendent. It's too much.
And
I don't have a clean answer. I'm keen to hear yours if you've got a cleaner answer than mine.
I mean, I think I have, when it comes to a trial protocol, I do have kind of clearer ideas. I wouldn't say, I want to say that nothing in this work is kind of clear cut in some ways, but I think if someone if they're coming into, say, in the trial I worked on, if they're coming into that sort of 10 weeks of psychotherapy with a cutoff, I would be concerned and have screened out people where they don't have a history of, let's say, if they've got one attachment figure who was solid, then that's great. If they have none and no current attachments, like no partner or family around, then those are the people who I would say, I'm not sure this is the right treatment, because it can,
100%.
at this precise moment for you, because of the cutoff, because that can be re-traumatizing for people who have a lot of attachment wounding. And not to say that it can't be really helpful for some, but I just think in the trial protocols, you know, I mean, there's been podcasts about this, right, where people have felt like they just really get dropped off the end. And there's a really good reason why people have to stop treatment, and there's a research reasons for that. But I don't think so. Those are the people I would say maybe not.
I love that you said that, because it's such an important point. We echo that as well in terms of what we'd seen. I'm remembering a couple of participants who were quite socially isolated and really kind of enjoyed the structure and the interactions that the trial afforded them. And then once that had finished, nothing sustained, because we were discharging them, and we'd sort of pulled them out of this isolated place, you know, with not great attachment histories either. No one of real kind of significance there. And they were kind of then just jumped back into that isolation again. And I really think that if you don't have some little kind of social support structure, it doesn't have to be huge, but if there's not one person, two people, three people around you that can kind of talk with you, be with you, we do. I think you're right, that idea of re-traumatizing, but also making people very aware of how profoundly isolated they are. And that happened. We had that happen. I think it was, you know, there's a lot of grief that one participant in particular had found, and that was more of an existential regret, I think, of you know,
not having those connections,
not having those connections, turning them down, and you know, that left that person in quite a painful place, which we worked through, but and actually, I have to say, it did lead to some good outcomes for that person. But we have to be really mindful of what we're doing, I think, and what we can make people aware of that they didn't anticipate. Yeah,
absolutely. Because it can get bumpy on the road to integration, right? And so it's helpful, you know, and I think, and so, and with the caveat of what I just said, like in the community space, that might be a whole different story, because there's not that same need for a hard cutoff as there is in a research trial, that people can maybe work with therapists or be in group spaces where they can connect, and so those people can be held in a different way. And I think so I wouldn't be so as concerned. I just want to do a lot of kind of wraparound support and make sure that was in place.
No, I think you're spot on. I think we're all kind of coming to that conclusion. One of the things I was I'm very interested to see where the group work kind of goes with this. So a good friend of mine, mentor Brian Richards, son of Bill, we're working on a cancer study, an open label in Baltimore, and they did it with a group model, and it was, you know, it made a lot of sense. And this group that became this kind of constant for all of them, and it continued for, I think, more than a year after the study had stopped, and they got a lot of solace from that. So, and obviously group dynamics is a whole other ball game. So that's you have to screen very carefully for that as well. I've certainly done group psychotherapy with borderline personality construct, and so you've got to be very mindful of group dynamics when you're doing particularly this kind of work. But they had, you know, really successful outcomes for that.
Amazing. That's great. So, I can't wait to hear about that trial a bit more. But so what can you say about the trial, just to wrap up that part of the conversation? So you submitted everything. It sounds like it went well. Can you say that?
It did go. I can say it went well. I can say I'm very happy with it. I think, you know, one of the things that I often sort of say, because we've got this is where we get the science bit of it that meets the spiritual or whatever you want to call it, but it has less taboo. Spiritual as a word in psychology has a lot of taboo, but it doesn't in palliative medicine, because it forms a very core part of the WHO definition of what is good palliative care, and we have to look at the spiritual needs of the patient and their family.
Yeah.
So that's something that we do. But the thing that is really interesting is that so many of these trials just look at symptom reduction.
Yeah.
But we can do symptom reduction with what we've already got. We can give people sedatives. We can give people antidepressants, and it just kind of flattens and douses symptoms, but it doesn't address them. So what we found, and and I say this all the time, is psychedelics aren't about symptom reduction; they're about transformation. And one of the things that we were really buoyed about, we saw reductions in distressing symptoms and psychological distress, but we also saw big increases in quality of life and spiritual well-being.
Yes.
Which is exactly what we're after. Yes. Decrease in hopelessness, decrease in demoralization. So we saw these big shifts, but the ones in perspective about their illness and about death were the things that were just fantastic to see. We probably had, I'd say, 4 non-responders in the group of 35.
That's pretty good.
Yeah, and look, nothing beyond. It wasn't for me. I didn't like it. Didn't find it useful. I won't do that again. That was shit.
And it's not for everyone, that's for sure, right? And nothing works for everyone,
Exactly. It made me anxious. I hated that. I'm not doing it again. And so, that's we did talk about that, but I think they read Michael Pollan's book and they want Michael Pollan's trip.
Yes, and his book has been amazing for the field in many ways, but also has challenges.
As a blessing and a blight, absolutely.
Yeah, absolutely. Yeah. Okay.
So that was I think in a nutshell, we were very pleased, and it would be wonderful to see more of that. I am interested to see how the group moving forward, how that would work. I think 2-to-1 is fantastic for clinical trials. It is not good for clinical practice. It is way too expensive, and it's way too time. It's just not efficient use of time. We could do this better, I think.
It'll be interesting to see how all of that goes. And there's, of course, more integration groups coming up now in Australia where people can go and be with other people who've experienced this kind of thing. So that can be really helpful as well, I think.
Well, it's wonderful. Yeah, we need it. So,
Yes. And I've said so many times on this podcast, the thing I find challenging about this field is that, in research, we have to tie things to diagnostic labels and to categorization, whereas actually a psychedelic, if I think about, it's not about that. It invites us to go much deeper than these labels. And then we have to kind of fit the results into them for the process that we're going to. But I know that on the trial I worked on and on your trial, you were looking at things in a much wider lens, which is great. And I hope that continues.
I think you're so right. It's like, how do we compress that person's life and their experiences that come, like they visit their entire universe. Like, it's just sort of this strange, so we're kind of reducing that to a clinical intervention, which feels absurd. And the researcher in me understands why we have to do that, but it's like, my God, it's so deeply personal. It can touch any aspect of past, present, future, which kind of collapses, and it's all available. Or we had people accessing ancestral kind of experiences, and and we've got a problem with that because science treats that as abnormal. But spirituality treats that as a mystery, and particularly when these experiences, give comfort or bring solace in that way. So I think we need language and training and systems that really honor that. I think our current model is much more about, well, that's pathology and that's it, and we reduce it to checklists, which is just
crazy. Right? In many ways feels crazy, but like I think. I was just thinking, I'm thinking about like what you're sharing about spirituality and, in palliative care feels really important. And I think about what drew me to this work, and a lot of it was that being able to bring together the spiritual and my interest in altered states of consciousness, but also together with my work in trauma and PTSD, and to feel like I could really hold those things, and you kind of have to.
Yeah. And was there a point where you went, yep, I think that's my next, like, what was that? Like, how did that come about for you?
Shall we go there? Because there's a big story there. Yeah.
I've got all day.
Yeah. Awesome. Me too, actually. All right. Wow. Okay. There's so many different versions of my answer to this question. And so I guess there was a point. I think, from a professional perspective, I spent years working in refugee and asylum seeker mental health. And so in that space, like your space, we have to hold spirituality as a really key part of our work.
Yes.
And because so much of the trauma of those experiences is a spiritual injury.
Yes.
And so you can't, I agree with you, like in mainstream psychology, it's kind of like, oh, we don't want to talk about that. But in my work, it's always been really important.
Yeah.
And so, and the kind of MDMA research around PTSD was kind of something I was interested in through my work at Foundation House, which is the mental health service I worked in for almost 10 years, actually.
Wow.
And then kind of, I guess, in the background, very interested in like yoga and meditation. And I had probably my first big experience of an altered state of consciousness was in meditation in somewhere in India, when I was very, very deep in this space, and kind of I kind of felt myself go outside of my body. And I had one of those kinds of experiences when I was in Goa. I wasn't Goa, where was I? I don't remember, somewhere in India. Yeah. And so it was those things. But I think the moment that it all kind of came together was after a serious illness that I had. So I was working really, really hard for a long time in the refugee mental health space, and I had my private practice. And then kind of, I reckon in 2020, I got really sick, and not with COVID. Actually ended up in the Royal Melbourne Hospital in the acute neurology ward with some kind of mystery neurological thing that they think was some sort of meningitis, but it took them ages to work out what that was.
God.
And and so I'd been working really, really hard for a long time, which I'm sure might have been part of how I ended up getting so unwell. And then I kind of had I went into the hospital, and I had this experience where I was kind of lying. I was unconscious in the bed, lying there. And I had this kind of experience that I won't go into the whole detail of because it will take a long time, but where I really felt like there was these women moving around my bed singing.
Oh my God. Wow.
And this is the full story, right, of what actually how I ended up in this work. And I kind of, I everybody says that those near-death experiences can be quite like a relaxing thing. Now for me, I was panicked. Because I guess I had that. I'm not ready. I don't want to go anywhere. I'm not up for this. Like, I want to come back. And so I had that real state of panic, and then I kind of relaxed back into it, and kind of, so, I don't know, I just remember this anxiety, and then I remember calm. And I guess from there, I had to reassess a lot of my life.
You have different eyes after that. You can't. There's something about the way that will. It's a strange one that. So I'm loving this story only because I'm not loving that you were so sick. But thank you for sharing that. It's such a profound shift when you are so unwell and you are sitting on that precipice of life and death. And I've obviously been at many bedsides of dying people, and the experiences that they have prior to dying, kind of vision states or and not delirium either. This is the ones that they're actually just at kind of, having these experiences or vision states or dream states, they move in and out of these sort of altered states of consciousness, and what they see and what they talk about is phenomenal. And you just go, wow. And it's very, really psychedelic, actually.
Yeah.
But,
yeah.
yeah. But the women, like, who were they? Were they like,
yeah.
who were they? I need to know. I'm sorry.
Yeah,
if that's okay.
Well, absolutely. Well, because there is a story there. So I'm not sure. And I guess I hold the mystery. We're talking about the mystery of these kind of states. I'm not sure. To start with, I couldn't see faces, just kind of the objects they were holding. But I actually panicked, kind of came to a little bit, and thought of a close friend of mine who was supporting me a lot during this time, and another friend. And I closed my eyes, and suddenly those two women were there. And so there was lots of other women, but my two close girlfriends who were very supportive and holding me a lot during this time were suddenly there. And so I don't know who the other women were, and I don't know what sense, like, I'm not sure what that was, but I do know that holding the mystery of it and connecting to it has helped me to kind of made some really big shifts in my life after that. So I quit my job at Foundation House, not because it was just time, 10 years in refugee mental health was enough for me.
That's a long time. That's way past the due date.
Which meant that I could then have space to come and work in this space. But that's a whole other, because I wouldn't have been able to take a job in psychedelics if it hadn't been for that, despite being really fascinated by it.
Yeah, I think, and the profundity of that is something that you can't just walk away from. I've had a very similar, I was very sick in 2004. I nearly died, actually. I had a ruptured appendix and then developed complications after that, and I became septic and had peritonitis. Anyway, organs started getting under stress, and my heart rate was up. And anyway, I had a special, and I was just, anyway, it was not good, and sort of in the middle of the night. And I remember sort of having this sense of, it was kind of a religious deity that, and I was like, one I was brought up with, I was sort of brought up battered Catholic. No longer practicing. But and then these sort of other, and they were female. And they were just there. And I went, I don't think I'm very well. And I knew I was pretty crook. I don't think I realized how crook I was, but I remember thinking if I did die, I wouldn't actually be upset because I felt that awful. But but then when you come out of that, that same experience that you had, you can't go back. And so I was surrounded, because I was, at the time, I was about 27, and I was surrounded by peers and friends who were like, I just want to, buy these shoes, and I think I'm going to do that. No, if I go out this weekend, and he's kind of cute. And I was like going, what's it all about, actually? Oh my God, we are so close to the precipice of life and death. So it propelled me into this existential place that I just was not, I was thrust into. I wasn't in step with my peers at the time. So that was an interesting time.
And do you think that is part of how you ended up doing the work that you do now?
Most definitely. Definitely.
Were you already a psychologist then, or
I was, So, and I'd gone back to study. So I did the 4+2. So then, and I just when I went into hospital, and I just put in my only application to go into the master's/doctorate. And I'm really glad I got in because I was really sick. So I thought I really wanted to work at end of life, and always had, which kind of stemmed from some early experiences losing my maternal grandmother quite young, and coming from a family where we just did not talk about that. And I'm like, well, where did they, like, what happened to them? Like, and why were they, why are we kind of kept away from this? So we edit dying people out of life. And I struggled with that. But, and what they were facing I had a glimpse of that when I was sick, but it was very quick. But it left me wondering what people face, and no one's really prepared to sit in that liminal space with them. But it's a profound time, honestly. So
I bet.
but then also moving into the hospice setting and seeing people having these quite profound, spontaneous moments of transcendence, similar to what you'd had in India, where it just kind of, and we would have these, I was very fortunate to sit with many people on their deathbed and hold many dying hands and hear stories and talking to them, and they go, "Oh, can you see, that's my mum out there. Oh my God, can you see, where's that light coming from?" And the room is completely dark, and or having them dreaming that they're everywhere all at once, and they have to tell you their life story, even though they're sputtering and can barely breathe. And then I'd go in to see them the next shift, and they were dead. And it was within days they would have these sort of experiences, and then I'd go back in to see them, and they were dead. 2 days later. So there's
such a humbling way, that such a humbling time to work with people, and to have come from having that experience, and then it sounds like others yourself, what, I mean, this is a big question, but it sounds like you went into that very existential space, and then has this work really helped you to kind of, I don't know, somehow integrate those kind of existential questions into your life and your work, do you think?
I think that's an ongoing integration.
Me too, I think. I was like, oh, who are those people? I'm still working that out. I've got a few ideas who those women were. I know who two of them were, but
it's so funny is that, I think I deliberately sought out a practitioner who was a Buddhist, therapist, a psychologist who was Buddhist.
Yeah.
I felt like how is it? I don't know if this is answering your question, but I realized that the models that were on offer felt lacking. I felt like it was
in psychology.
I felt it was very surface. I felt like it wasn't quite getting to the places I wanted to go with people who were sort of trying to articulate these very profound anxieties about dying and facing death, and it doesn't touch it. Talking therapy doesn't touch it. Very rarely does it touch it. You can get to those places perhaps with deep states of mindfulness, hypnosis, perhaps breath work, but nothing really got to it like psychedelics. But for me personally as well, I felt like I'd visited a place, and I'm keen to hear what your thoughts are about this as well, because as sick as I was, as unwell as I was, there was something very profound about being in that liminal space. And I thought, I really want to work there. I think that I'm just speaking as I'm thinking, because I've never really been asked that question, so thank you. But I think it was a space that I went, no, I feel comfortable here. I would like to sit with people in that liminal space where it's deeper talking, it's where we're really accessing really profound aspects of, and I'm sure I'm going to get hit for this, like all these people who are doing, psychoanalysis. I'm like, what are you talking about? We do depth work all the time. But to really hear it on a deathbed, there's nothing like it. And I think having our experiences, probably propelled us into this work,
into the psychedelic work, right? Because absolutely. It does get into those places. If I think about some of the things that people have shared with me after their psilocybin journeys, some of them are similar to what I experienced. Nothing, it's never exactly the same. And at the time, I had I really wanted to work in psychedelic research or psychedelic mental health work. But at that time, there wasn't much happening in Australia. This was 2020. So, I had friends in the UK that were doing it, but it wasn't like, oh, I really want to do this work, because it wasn't happening really. But I think it kind of, for me, I think it took me into this place of
I don't know, like kind of knowing that, I mean, from a very practical level, after that experience, I had to change my life quite dramatically because I was sick for probably 2 weeks in the hospital and then 6 months of kind of being out and trying to get better.
Yeah.
And so I had to make changes.
Mm.
And but those changes had been a long time coming, of course. And then so once I had the space, and I knew I had always just been having this feeling that there was something else I wanted to do. And so when I saw the work coming up, I thought, that's it. I also really want to work with people in that depth space, in that liminal space, to support people, because I really do, you know, I'd read the research around the MDMA for PTSD, for example, and working a lot in that space and seeing the results. You can't ignore that. Like the science does speak very loud. Right? You know, like we can. So I was like, I really want to do this work.
Yeah. It's extraordinary how, you know, an MDMA, and I haven't had the privilege of working with MDMA, but actually prior to coming into end of life, actually my doctorate area was on complex trauma. So I'm fascinated by what's possible with people who've just got very injured instinct and experience of trespass of the body, and how it can facilitate extraordinary healing. Like nothing else comes close. Nothing else comes close. So yeah. I was going to ask you a question, but I'm not.
Go on, please. Yeah, I'm sure. Let's do it.
Because I think so you've had this experience now after the psygad, and what psychedelic-assisted therapy. Well, there's two questions really, but I guess we'll go for the top of it. Or how that has changed your work as a clinician, but also how you've carried those experiences that you've seen.
Oh my goodness, there's so many.
Start where you like.
Yeah, there's so much to that question, you know. And I think I can say that we had a bit of a prep chat that you and I that we wish that we'd recorded, because
God,
it was like so good that we didn't. I've learned my lesson with that. I'm going to do that for next time.
And it was supposed to be like a 10-minute catch up. Like, we're going to talk about this, and an hour and a half later, like, oh my God, we should have pressed record.
Yeah. So
it was a glorious chat.
It was an amazing chat. And so I guess, you know, I was thinking about this off the back of that conversation of like, how has it changed my practice? Which is a question I often ask other people. It hasn't been kind of, and I'd love to hear your answer too, but I think, and how has it changed me as a person? So if I split those for a moment, which is also a bit false, right? But how has it changed? Like, I feel like in some ways, it's felt like a process of coming home to things that I've always known deeply, but it's kind of reinforced so much of what I've always believed about humans, is that this idea that with the right conditions and the right process, the psyche will move towards healing, and that kind of really core concept. And of course, a lot of people's lives don't have those conditions in them, so we have to support that and support them. But I've really seen that, and I guess it's really strengthened my belief in that, which means that I can get deep quickly with my clients in a way that I was doing before, but I think I trust that process more.
Yes.
I get out the way a lot more. I kind of, I've always tried to not put myself in the expert role of any kind with my clients, but I feel like there's a leveling that happens in this work that I've brought into other practice. Of course, there's still professional boundaries, but I think it's been really, really helpful in kind of, okay, so you have all these different diagnoses, but let's get to the core of what's actually going on for you. And let's talk about that. Let's name it rather than getting tied up in labels, which has never been something that I've been particularly interested in.
Yeah.
And let's work with that.
Nice.
I definitely, And I name, I think, you know, it's definitely also because of the countertransference and transference being so on steroids in this work. You have to name, you know, projection, which for people listening who are not psychologists or who don't know what that means, projection is where you see the world through the eyes of how you were brought up usually. And so you see other people as treating you as you were treated as a kid, right? And so I think I'm much better at spotting those in my general practice because they come up so strongly in psychedelic work. So those
Oh yes.
Yeah.
I love it. You know, I had we had this young woman that we were seeing and had a very, very powerful experience during the session of both myself and Justin in parental roles. And as she came out, she said, "Oh my God, you look so much younger." It was glorious. But wow.
Yeah. And that probably happens all the time, right? In our general therapy, but it's so like pronounced here. I've become dad and mom and sister and like annoying friend or loving friend or all of those things, and it's really important to talk about it.
Yes. Yeah. And it's wonderful. You need to pull it to transference in that way. And go, let's talk, about what's come through here. But it's so augmented. That's wonderful. And then personally, for you.
Wow.
I didn't forget that bit of the question.
I know, nor did I. I was like, I'm going to have to, and you know what I was thinking when I was thinking about, and you had a feeling you were going to ask me this, is just, I mean, it's been a profound experience for me personally that I guess began in that hospital bed, but also that I spoke about before, but also through doing this work, my whole life has changed since I started working in this field. I've moved out, from a practical level as well. Like I've moved out of the city. I've moved into nature more. I've moved in with my partner, which was huge as well.
Yeah.
And so I think if I really had to pick, I feel it's like something to try to say so many different things in a small sentence would be that I reckon this work has connected me more to my own soul. So I feel like, the self-experience and also the dyad, working in the dyad and witnessing other people, I've had to go to places within myself that I haven't been to before. And some of those have been amazing, beautiful places. And some of them have been the more shadowy places that we all have to visit.
Yeah.
I feel like much more clear in who I am, how I work as a psychologist and who I am outside of here. And I speak up more. I reckon that's a real practical.
Yeah.
And then there's so much, that I can't put into words about, the feeling. I just feel different. And in a really positive way. It's not always been smooth. It's been bumpy. But how do we capture that? Like in a research protocol,
I
right?
know. And how to, so many questions. That experience. And this is something that I've kind of just been left with as well. Because I think that with your experience that you had personally when you were very unwell, medically unwell, with meningitis, and then having that kind of profound, that was a psychedelic experience. So and then being witness to so many transcendent experiences or in the study. How do you make sense of, place these experiences? And was it something that fit within your ontological frame, or did it require a complete reevaluation? You don't have to speak about this if you don't want to, but I do.
No,
I'm so interested.
I think for me, I think having kind of practiced meditation and been, I guess, a word that gets a bad rap, someone with a spiritual practice for a long time, for my years of yoga and meditation.
Yeah.
In some ways, it was a familiar territory, but also not,
this makes so much sense. Keep talking.
It's the mystery of it. I think how I've made sense of it is that my job as a therapist in this space and a human is to hold the mystery. Like, I'm not sure. I don't know exactly what this is, but what's important is the person in front of me, how they make sense of it and how I make sense of it. And I think I think I've just got a lot more comfortable with that. I don't know. Like, I don't know what that is. You know, and that's okay. I don't have to know.
Yeah.
Yeah.
Absolutely.
What
I
about
mean,
you?
well, because I love it. I mean, in this way, we're just, we're not immune to this medicine. We're also shaped by it. And I love, and how that person in front of us makes sense of it. But the thing that we're not talking about, which I love that you are, and your whole podcast is dedicated to this, is well, how do we make sense of what we see?
Yeah.
And I'd had, like, similar to you, I'd done a lot of mindfulness, and I can't say I was a bad Buddhist, but I sort of had gone into Dharma classes. But there was a time where we were seeing and hearing so much about, people kind of having experiences of like something other than human or things, or giving them knowledge or whatever. And it could have been parts of psych, but it just sort of started to become, other realm, otherworldly, something more than human. And I was like, I don't know what this is. And even with that background, I actually asked for a closed meeting with some very trusted Buddhist leaders, actually, who were also mental health trained. And I asked for a closed group, and I said, this is, please hold this confidentially. And I obviously de-identified, but I said, this is some of the phenomena that people are experiencing. And I just want a non-Western science take on this. What do you think this is? Because I was trying to, so what am I hearing? This is far beyond anything that traditional psychotherapy had ever prepared me for. And even in my own spiritual kind of practices and things like that, I was like, wow, this is really out there. So.
Did it help?
Oh, the closed group. Well, it was so funny because I said, blah, blah. And then, we had one person, experience this, and, we had a number of people experience deceased relatives, all those kind of things, and kind of places that just felt very, there was a commonality to it, which was strange. And I kind of went, what do you think? And they just smiled and went, yeah.
I can imagine. Yeah, of course.
Like, dumbass. Like, of course. Like, we're Buddhists. You can access these states through meditation. So, which is kind of lovely and reassuring, and we all laughed our heads off. But that it's sort of the Western science has kind of hit these states, these altered states, and we don't know what to do with them.
No, that's right. I mean, and I think it's really, it's why we, in this field, we do need to be working with all kinds of disciplines. It has to be really multidisciplinary, I think.
Absolutely.
Not just that science practitioner.
I think that's the thing. And it's, and also that, what you were talking about before, about how the transference and countertransference is so augmented, and the need, though, to make sure that you can have those professional boundaries whilst balancing that profound connection, because it's, and one of the things that our participants said frequently was that after the dose session, their relationship to us changed.
Yeah, we had that as well. Yeah.
Which made termination that much more fraught and impactful. So, but
yes, well, that's a whole important thing. But can I turn those questions around on you now?
Sure.
So much. So how do you think this work and that experience has changed your practice as a psychologist or as a therapist? Or
oh God,
start there and then we'll go into the other.
Start there. Yeah. I'm so much more. I think I've de-emphasized the talking. Much more interested in kind of people's way of expressing. Like, for example, at the moment, I'm working with a couple of young women, and I'm asking them to do photo journals for me. Some of the things that they have with chemo is they get chemo fog, and they find it hard to find words, and it's really frustrating. They can't articulate their experiences, and I go, okay, I want you to start taking photos for me. in ways that capture what you're experiencing. And it has been profound. And they've gone, this has been a game changer for them, finding other languages, the use of music, the use of, kind of prescribing experiences of awe, or where you're more likely to experience things like awe. So asking people to go and do something and bring a particular quality of attention to it, so that they're like, I love Dr. Keltner talks about this in his book, which is wonderful. They did this experiment, which I love, where they had two groups of people. I think they were over 60, and they made them do selfies. They'd have to go for a walk and they'd have to do a selfie. But the ones that were instructed to kind of really, go very slowly, take their time noticing, things like veins on leaves and patterns in nature and all that kind of thing. The selfies that they produced were really, really interesting. So the first group, they were just taking selfies and, their heads in most of the shot. The ones that were asked to take more notice of the natural world, they would take a selfie behind this enormous, there's this tiny part of them and there's an enormous tree or this beautiful body of water, and that they were more, connected to the natural world in that way. So, and they were actually experiencing greater scores. How can you score all, right? But much higher in their sense of daily access of, their quality of life improved. They reported feeling much more states of awe. So I think I'm much more likely to kind of prescribe experiences, I think, in that way outside of the room. And there's talking, but there's also, what other languages do you speak? And so, yeah.
I love the photo idea, because you hear so often, don't you, in this work, that there's so much that happens that can't be expressed in words, but that's true in life.
Yes.
In general.
100%.
Yeah.
So that, and I think particularly for when to find other ways, because we can sometimes just not, in the same way psychedelics, you just can't articulate the experience in words. Sometimes those linguistic wrappers just fall woefully short. But that from that point of view, I think that's how it's changed me. The personal, again, that false split, which is a strange thing. I'm still figuring that out. I think that we were so intense, and you would know this. So when you're doing dosing every week or sometimes twice a week, which is just not possible.
No.
Don't try that at home, kids.
I've done that. Don't do it. Only a couple of times.
Oh God, yeah. Look, we were ruined at the end of it. Absolutely ruined.
Mm-hmm.
I think I came out of it and went, I don't recognize myself anymore. There was such shift, and I don't fully grasp all of those changes yet. They're still kind of making themselves known to me. In a very similar way, I need to be in nature a lot more. That's I'm from the country. I'm currently in the city, but I need to get out. I need to get back to nature. But I think as well, I mean, it feels like I was in a liminal space for 4 years. I was in an altered state, and I've just kind of come out blinking into the sunlight and kind of going, damn, I've got some stuff to integrate. So making, you can't unsee, you can't unhear those experiences that people had, and they were very tangible in the room. So I think I'm thinking about how I carry, I guess, those stories and those vision states that people are having, and those energies that kind of stay with us as clinicians, because they do, and how I process that and integrate that. And the creative arts are a big one for me, music in particular. And I think doing tangible things, I think, with my hands as well as big meditation. I'm a big meditator, so not great at it, but I keep showing up.
What does that even mean? What does that even mean? Yeah. You keep showing up. This is the most important
Just keep
part,
showing
right?
up. Yeah.
Yeah.
Water. I don't know why, but water is just such a profound place for me now. Soaking and I kind of had a lovely experience of kind of reconnecting with my own lineage in some ways, and so obviously, like, I've got a mixed bag. I'm quite a mongrel, but I've got a lot of Scandinavian heritage and Nordic heritage and Finnish, and so that being in sauna is amazing for me. And there's a lot of kind of folklore, and the sauna is quite a liminal space in Finnish culture, and this is where they would birth children. It's where they would have their dead. This is where the women would get together, and the kind of sauna magic. Like, it was quite beautiful. So I'm very interested in accessing other liminal states, not just the psychedelic. Yeah.
It's so interesting what you said about water, because I feel the same. Like, I live near the ocean now, so that makes it easier. But when I was in the middle of Psychedelic, kind of maybe 6 months into the trial I was working on, I rented a place in Janjuk, which is near the beach.
Yes. Yeah. Beautiful
place. And I honestly think that's what got me through without kind of, I don't know, there's something about the salt water that has always been a big part of my life. And, my family are, all kind of a family of people who grew up by the sea and were into sailing and all of those kind of boat kind of experiences. But I don't know, it was just something really profound about integrating the experience, because you do go into a kind of altered state with your clients.
We do.
Yeah.
And I think maybe, I don't know, I'm wondering now, I'm just kind of wondering out loud, but do you think that aside from the vicarious, but when we have to integrate, we're kind of doing this in rooms, we're doing this in clinical kind of settings, and it's sort of taken out of that wildness where we can experience those states of awe, the massive body of water, a massive kind of chasm of a beautiful view, and I think, I don't know, I felt like I was just running for it. I was like, where is this? I need to be in that. All of a sudden the I don't know, like, I think that, I don't know. What are your thoughts about that? I'm saying it out loud as I'm thinking about it, which is not very very elegant at all. But
I'm just really struck by what you just said about vicarious awe, because I actually haven't heard that phrase before, and I feel like that's so descriptive of what I experienced. And sometimes really hearing people going through huge, very emotionally charged, hard experiences too. And both which is
both
so
ends.
Much of our work, the dark and the heavy, and then into the kind of amazing expansive light, or whatever the mystery, whatever it is. And it does you do hold that in your body.
We carry it. I think we and how we carry it, or where it's located in us. I'm so interested in that. We're not talking enough about the impact on us.
No.
It's a wonderful currency in this work, but my God, it is.
It's both, but
it's both.
I feel like there's a whole other episode in that, in like, how do we, I've been thinking a lot about that, because I have burnt out in my career before.
Yes.
And not in this work, but in other work. And I just do think this work is both, it has the potential to be very intensive on your energy, but also gives so much.
It does,
I don't have the answer of like how we support the workforce as we move into this, but we need to be talking about it.
100%.
Yeah.
I thought about this actually. I was talking with someone the other day, because they said, "Oh, are you doing?" They thought I was just doing this full time now, and I went, "No," like, because Justin is obviously an AP, and we have a clinic. But we see mainly end of life. Like, that's our thing. That's so. But people were like, "Oh, yeah, you'd be doing this full time." I'm like, no one should do this full time. No one should do this full time. If they do that, they're not doing right by their patients.
Or
It's
themselves.
or
Yeah.
themselves. It's exhausting. So I almost wonder if there's a way. I mean, it would be great to see, because like, what does it look like? What's the ideal model? Who knows? But I think and we do look. We actually do PAP for end of life, and occasionally. But again, it's not the 2-to-1 model is a very difficult one in practice. But I think that if we were able to do it in places where it was either, low cost, no cost, public funded some way, with a group, so it made more sense, carefully screened and carefully held. But you would have rotating teams, because otherwise you're just exhausted.
I know. I was thinking about for myself, it was what frequency would work for me if I was going to work in this space, and it every dosing every week was kind of, I don't think that's sustainable over a long time. I could do that for a period and then rotate, or is it every other week, or is it every month? I don't know. I think it would depend on the person, but I do get nervous about kind of these models that want to roll out kind of really clinics with people dosing all the time, and I don't think it's wise for anyone.
No, it's 100%. I think you're right. If there's a period where you can tap out for a while, because you have to process that. You go to these really profound places with people. We have to take care of ourselves. And also, even if they're not they can have these really challenging experiences. That is full on, like the way you're cast, and what you're holding, those projections is really, really intense. But I think, that who knows what it's going to look like. I think, but you're right. Wasn't there, I think, was it Synthesis in the Netherlands, and it folded. I think they were trying to scale up because they had this overwhelming demand, but therapists were just burning out left and right. It was, I thought I read there was, some therapists had talked about it, and they just said it was just too intense, and it was just relentless, and they couldn't keep pace, and it was, that's what they had. There was quite an extraordinary existential burnout, I think.
Yeah. And I think in order to hold space for the awe that you get as well, you need that time, you know? And I think that I think if I think about, myself and how this work has changed me, I think my capacity to connect to awe is greater.
Yes.
For sure.
Yes.
For sure. I see it more. I think I'd like to think I'm quite I like to be in the magic of life. So I have that, but the capacity to do that anyway, but it's definitely got bigger. And
yes.
In the little things, in the vine, the leaf or the bird, or,
100%. And how you can just kind of drop into it and feel the intensity or the magnificence of that tiny moment, which is quite beautiful. That's been a gorgeous side effect. Actually.
Yes.
But I think we've got it's a funny thing, because for those of us who have had the privilege of working in this arena, we all get it. We all get this, like, what do you do? And we talk quietly, like, how amazing, blah, blah, blah. And then we talk about how we decompress, how we, and so much of that is people just running to the edges of nature, and then finding the awe.
I think I feel more connected in my body to the things that bring me joy, and and those things might be small things like nature, or my cat, who's a very small fluffy thing who's around here somewhere, and just feeling I feel those things more in my body as a result of this work, both what I've done personally, but also seeing clients.
Phenomenal. It is. It's something I would never give back.
No.
Oh gosh.
So I have one more question.
Sure.
Is that all right?
That's absolutely fine. I was thinking, my gosh, it feels like 15 minutes and we've been going nearly an hour and 20 minutes.
I know, right? So I guess, and it's a slight, like, I mean, we've covered a lot of what I was hoping to talk about, but
Yeah.
one of the things I did want to, you're a female leader in this space, right? In a space that traditionally I feel has had a lot of male leaders. And
Yeah.
so what's that like? And what advice do you have for other women wanting to kind of come forward in this space, I guess?
Yeah, thank you. That's a very important question as well. I think I was, so I have to say, Justin, who is my Justin Dwyer, who is a psychiatrist, and he's my therapy dyad colleague. But we also worked together for many years. But he was sort of the person, had to say yes to this. And he was an extraordinary support. And he just said, his philosophy, as he said, was, hire good people and get out of their way and let them do their thing. And he did. He just kind of let me do my thing. So I was surrounded by people like himself, Mark Bowie. These were males that were absolutely fantastic, very supportive. Because ultimately there were emails that came in that said, "Oh, hi, Dr. Dwyer. Hi, Dr. It went to the males. Can you tell us more about your research? And they'd go, actually, Marg Ross is the lead investigator. Here's her email. Like, so, it was, there's that. But if you've got, if you're surrounded by people who are very supportive, that makes that easier. But yeah, there's always that kind of, unfortunately, there's a big overrepresentation. Sometimes you look on panels. I think
Manels.
Yeah, M-Time calls them manels. I laugh my head off. But and I had really strong women in the team, which is great. I have a fantastic one of my work besties who was on the team, Paula Kallianis, gorgeous social worker, and I'd worked with her for a decade in Parliament. So she was like, yeah, come on, she was a great cheerleader. I was around strong women. This was wonderful, very, very powerful for me. And I come from, we're all women in my family. I'm one of 5 girls.
Wow.
And I have 5 nieces. So we can't produce boys in our family. So, and my mother was very strong. Her background, the women were very strong. And, it's just like, no, you go out and you do what you want. Work hard. Don't rely on someone else. Love many, trust few, paddle your own canoe.
Nice.
Which was one of her favorite quotes. That I think comes from Native American literature, but that idea that, okay, well, I had this idea and I'm just going to try and build it. But I had a wonderful support around me. But I would say this, if you're going to do it, absolutely do it. Don't think, and also I'd have to say this, don't ask for permission.
Yeah.
Forgiveness is easier. So
yeah,
do that. Yeah, I think, I was judicious about where I asked for permission, and obviously I followed all the things I had to do and but I knew if I'd gone some places that I probably would have been stopped, discouraged, actively discouraged. So I went where I needed to go.
Yeah.
And surround yourself with strong women.
Yeah. And also in your, supportive males or other, I think we need all types of human in this work. And, there's lots of different parts of society that are underrepresented in academia in general. It's not certainly not unique to psychedelics.
Not at all.
And I think for a healthy ecosystem, we need all people, all types of human, all genders, but I think it's shifting, but there's still work to do.
Oh yeah, I mean, there's a I feel like I want to write a paper about the silent side effect, which is narcissism. There is a lot of inflation in this community. That's just across the board. So people go, no, it's my way, and I'm the without realizing there's a space for everyone. There's actually enough space for all of us. Some people can get very threatened, or so there's a lot of jostling. You see it in academia. You see it in you kind of see it everywhere, unfortunately, and it's in the underground. There's all sorts of characters sort of walking around. But I had one of my greatest teachers, Luis, Eduardo Luna, and he said, narcissism is the thing that's just not talked about here. There's a lot of spiritual inflation. There's a lot of, I'll do it better, my way. Yeah. So unfortunately, sometimes you think you're coming into, something that's all, love and peace, and it's pistols at dawn, like
my good friend who you also know, Simon Raphael, said to me that he got into psychedelics because he thought that would be like a more kind of a part of like academia that would be more about peace and love and connection, and realized it was even worse than academia.
It's just he's correct. He's absolutely correct. Yeah. It's so, and it's just, there is at the moment, because it's still new in this arena, I say, because it's obviously extremely old, but there's a lot of like, jostling for terrain. So, but I think, there's, it's good to see that some of that is simmering down a bit. There's, I think that people who are wanting to make a quick buck, riding into town, and they're sort of starting to fall away a bit, which is good. And then you'll be kind of left with the people who are more serious about the research and the work, and that's what we want. Yeah.
Yeah, it does feel like, the way things got rescheduled here, there was that kind of, other people have talked about it in other countries, it felt like a bit of a gold rush, like people were kind of, all these companies and wanting to kind of make lots of money.
Yeah.
And it's become very quickly apparent that that's not actually possible, and maybe that's a really good thing.
That's actually a really good thing, because again, we haven't figured it out yet. We haven't figured out what model would work and how we can prepare people for this. They've still got really bent expectations about I'm just going to lie back and it's going to reset my brain, and we move them into very passive recipients if you follow the cultural dialogue of it. But they're just so true. We're like, no, you've got to work hard. So we've got more work to do, I think. But that will come in time.
I think so too.
Yeah.
And I think, there's a lot in what you just said, actually, about like, it isn't, I've spoken about this before on this podcast, that, this psychedelic work is something that you have to show up for as a client, and that you have to kind of, it's not a straightforward like path where you get to reset your brain. It can be bumpy, and my own integration experiences have been bumpy. My integrating sometimes this work, just actually being a therapist, can be bumpy, but those bumps are really important part of it.
Those are the ones that actually probably, arguably, would produce the biggest changes and the biggest transformations. So I think it's really tricky, isn't it? Because we just I think we really have to work with that. The thing that, and I think maybe I'll say this, maybe you'll edit it out, I don't know, talking about how psychedelics have landed in a consulting room, that if you just pay enough, that you'll get a transcendent experience. And it's a strange thing what that does to it. Like, and I think this is where I think the people who are kind of going, we can make a lot of money out of this, did not think about this. And you can tell they're not clinicians, because if you're a therapist and you've got someone who's just walked through the door and they plonk themselves on the chair in front of you and they've gone, I've just paid how many $1,000 to the receptionist out the front. I've done my bit, fix me. The expectation, like, it completely changes the therapeutic dynamic and their expectations of it. And it doesn't matter how much you work with that. If they've paid that money, they're expecting results. So, we've got a really strange model in that way. And it's not good for the therapeutic relationship. And they haven't thought about that.
No. I think expectation effects are a huge problem across the board, actually. It's more intensified in clinical practice, but we certainly saw that on the trial as well, that people have kind of read Michael Pollan's book, or they've watched a documentary, and they, no two psychological experiences are the same, no one's journey is the same. So a lot of our work was about kind of initially going, okay, this is a trial for anxiety disorder. We have so we're going to see if this helps you. We hope it helps you. And you might get placebo, which for some reason I ended up with I think out of all of my participants, I'd say probably 70% were placebo arm.
Oh my gosh.
Which actually what it meant was that I worked with people for so long therapeutically, because then they moved into the dosing arm.
Wonderful. Yeah.
So actually I did really long-term therapy first. So
That's
it was
great.
very interesting.
Yeah. Well, and just, sorry, this is just a quick question by that.
Yeah.
In terms of how you see preparation and the length of preparation, and what are your thoughts about that?
My personal opinion is that a good chunk of psychotherapy first is better. Yeah, for most people.
We are absolutely in the same.
Yeah, for most people, like it depends. And it doesn't have to be, there's lots of different models. There's a trial that's going to be starting where I think like the psychedelic therapist joins with the person's actual long-term psychotherapist, which could be a really good idea.
Yes.
That could be a way to do it. So they come in for some dosing.
Yeah.
But yeah, I mean, in my ideal dream practice, I would be working with people for quite a long time first.
Yeah.
Not everyone, of course, caveat with every kind of therapy. But I think there's something really good about the long-term therapy first.
No, I'd agree. Sorry for that little diversion, but
I think
it's yeah. Oh my gosh, so many questions and so many.
I know. We've covered a lot of terrain, Marg. Is there anything that we haven't spoke about yet that you want to talk about?
I think that's kind of it. I mean, I've got I could talk about your experience for days and what that meant for you, how it changed you, how it so closely aligns with your work. I mean, and what you see, and I guess deepens your empathy for where people kind of move into those places. But yeah,
I mean, I have a question for you, which I've never been able to ask anybody, because you're probably the person who has sat with more people at the end of life. Does anybody else have that experience of, because all the books that I read were sort of, it's going to, you feel really calm. And I did, but my initial feeling was panic.
Yeah.
Like I was like, I'm not ready to die.
Yeah. Which is good. That's your that's your life preserving instinct there. Good.
Yeah. Right. Have you heard that before? I'm curious.
That it gets calm.
No, that people have the panic part first.
Oh yes. Oh yeah. I mean, that's awe, isn't it? I mean, I loved, there's a wonderful definition of that where it sort of says that, awe kind of lives on the upper reaches of pleasure and terror.
I love that.
And so there's a and you see that, you can see when people move into those terror phases, and you can see when people kind of land, and it's tangible in the room. The way I've heard it so beautifully put was one of our participants in charge said, "I'm in a state of grace, Marg. I'm just in a state of grace." It was like, oh my God. And it was so tangible. So yeah. But yeah, terror is that's that life preserving instinct. Sometimes you can have that, and then you can burst into something numinous that often gets quite dark. We have people who go through quite hellish or malevolent experiences, but we're like, just get curious, keep looking, start interviewing it, get curious. What's it here for? Dive into it, and then it would burst into something numinous. I think that's the dying before you die experience in a psychedelic. I think at end of life, it really depends on, I guess, the existential maturity of where that person's at, as well. I think I'd have to say the people that do dying worst would be narcissistic white males.
Fair. I'm not going anywhere. Yeah.
How dare I'm going to die? Me? Like, I can't die. Like, they're usually terrified and not at peace at all.
Well, I think, it's interesting that I was curious about that, because when I think about, I'm just processing in real time here, like that experience of anxiety and then calm is what so often we held space for in on the trial. People would go into this, like, sometimes psilocybin is strong as well, right? So it kind of comes on and there's anxiety, And then there's something frightening and people move through that. That's the in and the through. And I guess I just did that in a small way with that experience, or in a big way, maybe.
Yeah. Or just kind of going, well, what is this? And you kind of, the curiosity moves you through. I think if you can kind of find a way to, in our flight instructions that we give people,
be curious,
see what's there. Yeah, what is that? You've got, it's a manifestation of your mind. You've got every right to ask it why it's there and what it's doing there, what it's going to teach you. So that can help move through. But I think, you certainly see terror, you see peace, you see, moments of like, it's almost like the reverse of giving birth in a way. Like there's something very profound about it. A lot of family members will come out of it kind of going, that was the most devastating moment, losing my loved one, brother, sister, mother, father, but it was the most sacred. I don't know what I witnessed, but it was so, these are profound states. And I've been with people at their deathbed and when they have died, and it's the closest thing is this just being with someone in a psychedelic experience.
Yeah, totally.
That's about as close as I can describe it.
So. And that, so I said this earlier, but so humbling to be there in that moment,
Yeah.
Wow.
Yeah. Takes your breath away, and there's no words.
There's no words. I was just trying to, I in my younger years was a nursing assistant on an older adult ward, and so I have had that experience just a couple of times, not to the level that you had, but I was so deeply moved. I've never forgotten it, ever. And we would open the window so the soul could go out, all those kind of traditions in Wales where I grew up. I was like 20 at this point.
Oh, how beautiful. There's some extraordinary beautiful folklore and rituals in Wales as well.
I know. Yeah. We've got a lot.
And it was, there's nothing for us to sort of see that in the hospice. This is kind of the lovely aspects where the humanity kind of mingled with the Western science of it. So we would go get some flowers from the garden. We would do this. We would do all sorts of things. And so
beautiful.
Oh my gosh. Wow.
Thank you so much, Marg. What a great conversation. I feel like I could keep going, but I think we should stop now.
An hour and 40 minutes, nearly.
I know. It's
easy to do. It was a wonderful chat. Thank you so much.
Thank you so much. And I look forward to keep continuing connecting. And thank you so much for coming on the podcast.
My pleasure. Thanks for having me.
Thanks for listening. If you're interested in following along on the journey with me, check out my Instagram or website details listed in the show notes. And if you enjoyed this episode, please leave a review and share this podcast to help get this important conversation out to more listeners.